All right, just gonna give it a minute till everyone's here. Okay, it looks like we are live as well. All right, hello everyone. Welcome to another eShadowing session. I'm not one of the typical hosts for today's session, but if you're new here, don't know who I am, my name is Caesar, creator of the program. And as always, super stoked to provide these sessions for you. And today we have our presenter, Dr. Isreb, who is specializing in integrative nephrology, and he'll be sharing his experience in medicine and his specialty. And before we get started, I want to make a couple of announcements. At the end of each session, for those of you that are new, there's going to be a Google Forms posted in the chat, and it is time sensitive. So once you see it, make sure to click on it right away. I'll give you guys 2 minutes to click on the link, and that'll be it. And also, for those of you who want certificates for your participation in this program, just know that certification is based on total amount of hours. So it's not like you join the session and you get a certificate for just this session. It's based on continuity and all of the sessions that you participated in and got your hours for. So towards the end of May, I would say May 20th is the confirmed date. Feel free to email us at premed.eshadowing@gmail.com. I'm going to post it in the chat. So you would email us to request the certificate, and we will issue it to you by the beginning of June. Now, with all that being said, Dr. Isreb, whenever you're ready, you may begin.
Perfect. I'm just going to plug in my mic here. So can you hear me?
Yeah, audio is fine.
Perfect. So, well, I'm Dr. Isreb, a kidney specialist, and nephrology is the field. And I'm going to be walking you through my my journey and then talk about what nephrology is and what is integrative nephrology, because this is actually a new field in a way. So I am actually originally from Syria. So if you don't know, I'm here. I've been here for 25 years. And really, what I want to say is and a lot of this is a little bit. There's some cynicism in my talk, and so hopefully you enjoy it, because there's a lot of honesty. I'm not going to be sugarcoating things for you. I'm going to be talking about how I went through my journey and what it ended up being, where did I end up being, and why did I end up being here, and talk about the options and so on. So in the beginning, I really did not want to go to medical school. So back home in Syria, when you graduate from high school, there's a national exam. And according to that exam, there's a matching program where if you score high, you go to informatics, then medical school, then dental school, and so on. So, and there was I scored enough to go into medical school, and the prestige over there, you either be a doctor or engineer. So my parents pushed me, and I used to love math, and I wanted to do something related to math, but that didn't happen. So in the beginning, when I went to medical school, I actually was in a rebellion for the first semester of medical school. I went to Damascus University School of Medicine, but then somehow, whatever happens, I end up falling in love with anatomy, and it went from there. So I took it seriously, and I started doing more, went on the path of medicine. And finally, my parents ended up migrating to the US. Actually, my brothers came into the US before me. And as I finished medical school, I really wanted to do ophthalmology. So that's what I wanted to do. I actually started an ophthalmology residency back home. And then in the second year of my ophthalmology residency, I ended up coming to the US. And, it was so difficult to get a visa to come in that once I came here, I really did not feel like I want to go back and try again. So I stayed here. I did some research in ophthalmology again. I tried to apply for ophthalmology, but at the same time, I had a backup. I applied for internal medicine. And ophthalmology is so competitive for foreign grads. I actually got only 2 interviews for ophthalmology, where I got like 45 interviews in internal medicine. So it didn't happen. And I ended up in a program in Chicago, affiliated with Northwestern University. I learned really good, it was a great experience, a good program. And, with time, I ended up having interest in nephrology. So nephrology is, if you know or you don't know, we deal a lot with, we'll talk about that in a minute. So it has something related to math. So this probably the background of loving math and formulas and all that probably got into me when I was thinking about nephrology. But lucky for me, nephrology became competitive that year. And also I was trying to apply and it didn't happen really around that time. And so I applied to be chief resident, and in the program that I was in, and another program also, I applied for chief residency program for a year to give me time to reapply for nephrology. And there was a lot of drama around that time, because the program directors approached 4 people to be chief residents for 3 spots. So I wasn't really sure whether it's going to be a slam dunk that I'm going to be a chief resident. And I didn't want to really, jeopardize my position. So this is why I looked for other places. And, another, part of this is that I was on something called J1 visa. So J1 visa in when you're from, like Syria or other countries, you have to do 2 years of working in an underserved area to kind of get a J1 waiver that you can transform it into H1B. Or if you started on H1B visa, you don't have to do that underserved area thing. So that's unique to a foreign medical grad. So many of you, if you're like a US grad, you don't have to worry about this. But, so I told my I told my program director that I'm going to be chief resident. I'm going to work on that. But then on New Year's Eve, the position opened at Loyola University Medical Center, and the program director called me and said, "Hey, do you want that position?" And I'm like, "Yeah." And that was like actually in a way that I will not be a chief resident, so I have to say no to the program director. So that led to a lot of friction near the end of my residency. Again, a lot of drama. I'm just telling you my life story so that a lot of it has to do with also being, again, a foreign grads. So ended up going to Loyola University Medical Center for nephrology. And really, I feel like that's where I shined. I really, like nephrology. People loved me, nurses and staff and the faculties. It was a great fit. Very nice program, busy, but all the nephrology fellowships are busy. So during that year, that 2 years, so the fellowship for nephrology is 2-year program. So I got married in between the first and the second year, because around that time also 9/11 happened. So I couldn't really go to Syria to get married and come back right away. You had to reapply, and it was a big, there was a lot of scrutiny around that time, especially being from Syria. So yeah, it took like about 4 or 5 weeks for me to get that visa back to come back for my second year of my fellowship. And during that time, I missed a huge deadline because because I'm being on a J1 visa, there's a program called State 30. At that time, I don't know if this is still the same right now, that gets you to apply for that J1 waiver, and there's limited spots. So there are 30, used to be 20 and then 30. I don't know how many now. So, but being a foreign grad, you have to apply for position for a job, at the end of your first year, not in your second year of fellowship. So I ended up missing that deadline. So I ended up having to really wait for a few months after my my fellowship to start a new job in an underserved area. And I worked in New Mexico for a while. So so that really, I worked in New Mexico for 3.5 years, serving, big, large geographic area. If you're familiar with the Four Corners area, so that's where New Mexico, Colorado, Utah, and Arizona meet. And there's a lot of Native American there. The Navajo Nations, if you're familiar with that, is there. And I served there for 3.5 years, driving a lot. And it was a great experience. So no regrets for sure. I've seen things that I probably would never seen if I didn't go that route. So how did I become a nephrologist? So then after that, I moved to Southwest Washington here in Vancouver, Washington. So not Vancouver, BC. And Vancouver, Washington is where I've been for the past 13 years. So, the way to become a nephrologist is you take 3 years of internal medicine residency, then you take a board exam by the ABIM, and then 2 years of nephrology fellowship, and then there's a board exam for that. And you're ready to go to practice nephrology. Now, there are subspecialties in nephrology that, we can talk about those. I am just a general nephrologist. You can call me community nephrologist. So what is nephrology? What do we really deal with nephrology is we deal with dialysis, transplant, electrolyte imbalances management, and hypertension. These are the four major things. So dialysis is really the bread and butter of nephrology, where we take care of dialysis patients, prepare them for, pre-dialysis, taking care of their chronic kidney disease, and then take care of them on dialysis. In terms of transplant, we don't do the transplant surgery. So this is a misleading picture for you. So we actually prepare the patient in collaboration with the transplant center for the transplant, and then we manage them medically after the transplant also. So that the first period after transplant for 3 months or so is mainly managed by the transplant center. And then once the patient is stable, then they pass them back to us to manage them. So a lot of that is, we work with them on an ongoing basis. When you talk about electrolyte imbalances, this is kind of where what I told you, that there's a lot of formulas and a lot of math and involved in calculation and learning about, sodium imbalances, potassium, calcium, magnesium, phosphorus, all these things, water imbalances. They're all, this is what we do. And it is fascinating, but actually, in the big scheme of things, this is less than 5% of what nephrologists do, to be honest with you. In a way, right now, we'll talk about that in a minute. Dialysis is, like I said, the bread and butter, and this is where, it's easy peasy. When we start talking about electrolyte imbalances, sometimes it becomes like not a liability as much as like liability in terms of it's like it takes a lot of our time for minimum return. Just being frank here. Hypertension, we deal with hypertension. A lot of it has to do with helping, especially in refractory cases of hypertension, where the primary care physician doesn't know how to handle the patient, or looking for other causes of high blood pressure. So primary, like, or essential hypertension versus secondary hypertension, where there's other causes, which could be, the adrenal gland. It could be narrowing in the arteries of the kidneys called renal artery stenosis. There's other rare things like pheochromocytoma, where we produce a lot of, adrenaline. These are the things that give us the fight or flight reactions. So we do that workup, and then oftentimes we end up managing the blood pressure for the primary care physician at that time. So I talked about math and how my love to math translated to electrolyte, to my love to electrolyte management, which is really what got me to nephrology, I think. And there's a lot of formulas and a lot of things that are related to the management of sodium and potassium. I actually didn't mention acid base. So acid base, we also, is one of the things that we handle, is the acidity of our blood, pH. This is more complex, and a lot of that is something we deal with, and there's a lot of formulas associated with that. But as I said, this is about 5% of what we do. So the bread and butter of nephrology is in dialysis. And frankly, and unfortunately, the nephrologist's worth is the number of dialysis patients that they have. So because there is something called MCP, which is capitated charge. Most of dialysis patients are Medicare patients. So they end up, Medicare will pay you capitated charge every month to see those dialysis patients, care for them, develop care plans for them. And, if you see them one time a month, you get paid a certain amount of money. If you see them 4 times a month, you get paid more amount of money. So, this money is coming whether you're working in a clinic or you're not working in the clinic. So all you have to do is see the patient on dialysis 4 times a month, and you get paid, for the dialysis patient. Now you can have allied health professionals like nurse practitioners, PAs help you so you can round 1 time a month, and then nurse practitioner round 3 times or 2 times or whatever you have that arrangement. The 1 time has to be done by the nephrologist, and a lot of practices do that so that the nephrologists have more time to produce, more by seeing patients in the hospital and the clinic and so on. And while the nurse practitioner deal with the other dialysis visits. So that is really dialysis. And really what I want to say, dialysis is highly, highly regulated. So this is where, because Medicare is, deal with this, for so long, there's a lot of regulation. So it's not walking in the park. It's different than how we practice other, specialties. So they follow, like labs and so on, that we target specific outcomes for dialysis patients. So we think about dialysis, when we round on them, we look at anemia count and acid base and phosphorus control, calcium level, blood pressure control, volume status, if they have too much fluid or less, if we're removing too much fluid off them on dialysis. And there's different type of dialysis. So there is what's called hemodialysis, which is that you have a shunt in the arm, and that can be done in center. So call it in center hemodialysis. And hemodialysis can also be at home, so it's called home hemodialysis. And the other type is called peritoneal dialysis, and peritoneal dialysis usually at home, and that involves putting a catheter in the belly, and the patient will go through training, and they will put fluid in their belly, and that fluid equilibrate with the toxins in the blood over a period of time, and then the patient will drain it. And there are machines that can do the peritoneal dialysis for the patient at night while they're sleeping. So they will have, the machine will put in fluid and drain it while the patient's sleeping. So again, there's a lot of regulations related to dialysis. So, before I talk a little bit about, other aspects. So, a lot of people don't think how important kidneys are. So the kidneys are, not given credit for a lot of things that they do. So I mentioned how we're responsible for making sure anemia is under control and so on. The kidneys, not only get rid of the waste products. So, we filter the blood in two stages. Stage one is these glomeruli, which is these tiny tubes where a large amount of blood get filtered and goes into the second stage. The first stage I call the stupid stage because there's everything is going through except for large cells and proteins. But if that stage is the only stage, we'll end up getting dehydrated pretty quickly, and we lose a lot of salt and minerals quickly. So that's why the second stage, where the tubules are there, these are the tiny tubes where the urine goes, the filtrate goes through, and a lot of it gets reabsorbed and fine-tuned to the needs of the body. So this is why we balance sodium, potassium, calcium, and so on. But also these tubules have, they produce hormones. So we produce a hormone that boosts the bone marrow to produce blood. That's called EPO or erythropoietin. And that's why a lot of kidney patients, with time, they end up becoming anemic. They also produce or activate vitamin D, which is, vitamin D is actually more of a hormone now, is being thought of. So a lot of kidney patients also end up having low vitamin D, and that can cause the bone to be weak, and the calcium, instead of being placed in the blood, in the bone, end up accumulating in the blood vessels, causing vascular calcifications, which can lead to bad outcome in dialysis patients. And again, I mentioned, phosphorus get excreted by the kidneys, so managing phosphorus with dialysis is important. And we look at the blood pressure, and the kidneys, also plays an important role in balancing blood pressure control. So, there's a lot of things that goes into kidney health, and they affect a lot of things. So, I hope you, at least if you don't end up being a nephrologist, you think about those kidneys as really major organs that produce a lot of things to keep our body healthy. So, I want to talk about this 21st century medicine, and I do, in a way, over the past 10 years, medicine has changed in a way that is, to me, is negative. So we start, there's a lot of things about electronic health records, and the government said you cannot just only use electronic health record, you have to use them in a meaningful way. So they're like, you have to, when you're like sitting with a patient, instead of paying attention to the patient, you have to make sure that you're looking at the computer and doing the things that the government wants you to do, and clicking buttons and making sure all of that. And a lot of it ends up tying into your reimbursement and how you get paid. Another factor is these prior authorization. Every time you try to, you want to prescribe a medication for your patient, or do procedure or things like that, you end up, having to go through the insurance, and the insurance may say, no, we don't want this drug, try this drug. And if you don't, you try to do this drug, and then they will say, no, I actually don't like this drug. So yeah, a lot of back and forth, a lot of paperwork that end up making, care in general difficult. And that's not really specific to nephrology. This is everywhere. Unfortunately nowadays, medication pricing is a big hurdle to be able to practice medicine in a meaningful way, and without having the patient thinking about, do I have to eat or do I have get my medication? So it's a lot of problems, and a lot of patients, themselves are eating their, kidney disease is rampant in low socioeconomic status in marginalized communities because people are getting, they don't have enough money to find good healthy food, and they're eating bad things for them, and that end up leading to diabetes, hypertension, and kidney disease. So in 2016, I had this epiphany where one of my friends told me about this Institute of Functional Medicine, and you can Google it, ifm.org. And so I attended. They have this applying functional medicine in clinical practice, a week course, and it's not cheap, but it was really I enjoyed it. It actually make you think of medicine differently. So you go back to what you learned in school and how everything is related to biochemistry and genetics, and you start thinking about the different ways of approaching medicine, instead of here's your disease and here's a medication to kind of treat what you have. In a way, conventional medicine, it gives people things, medications to help them live with their disease instead of kind of cure the disease. But in the paradigm of functional medicine, you try to look for the root cause and try to reverse the course, and try to cure disease upstream from the root cause of the what's caused this. So instead of thinking about kidney disease, you're thinking about what caused this to happen, what caused diabetes to happen, why is the patient has insulin resistance, and so on. So, so I went through the IFM has a certificate program. You go through, there's a lot of modules that you have to take, and a lot of them can be done online nowadays. And then I became IFM certified. And in 2018, I established Integrative Kidney Solutions, which I became Integrative Kidney Institute. So basically, I apply the integrative principles to manage kidney disease and to teach others how to manage kidney disease. So I hope you get a chance to visit our website, www.inkidney.com, and learn some of the stuff there. We blog twice a month, so some of the stuff might be helpful for you. And what I currently practice in a way is a hybrid model. I still have the conventional model because otherwise I cannot make a living, but because unfortunately this is the way the system is built. And also I do manage the integrative side of things. The administrators here ask about, to give you example of a day in nephrology, and I'm going to talk about a day in a regular nephrology practice, not an integrative practice. So, in my conventional way, I have one hospital week and one clinic week. When I have the hospital week, I start the day rounding in the dialysis center, about 22 dialysis patients. So you round through them, check the things that we talked about, their labs and their blood pressure and volume and all that stuff. And you examine them and you document on them. You may get paged during rounds. You may get texts from the hospital for a patient who, needs something urgent, or a hospital has a question for you. You can get called before, during rounds, and get interrupted often. So, and then I go to the hospital. I see the consults that I have. I round on established patient, and some of them have acute kidney injury, electrolyte imbalances, as we talked about, volume issues, dialysis. And then I go back and do the second shift in the dialysis unit. Again, 22 dialysis patient. And this happens about, like, let's say on the hospital week, Monday and Tuesday is like this, because I don't round in the dialysis center on Wednesday, Thursday, Friday. So the other days, so on the hospital weeks, Monday and Tuesday, I round on dialysis patient in the unit on the first shift, second shift, and third shift. And third shift usually happens after 5 o'clock. So those days I usually don't get home until like around 7 p.m. or so. There are some other programs that do nocturnal dialysis. You're not going to round on a patient in the middle of the night. So those patients, you end up seeing them in the office. The other days in the week, on a hospital week, I do the rounds during the morning, and I leave the afternoon for urgent clinic consults or even some routine follow-up. And the clinic week is pretty much 9 to 5 job. Again, this is where I practice the hybrid model of integrative and conventional medicine. And prevention is most important here, because you can do a lot of things to prevent the patient from ending up on dialysis. So, one of my passion is to decrease the epidemic, what I call the epidemic of chronic kidney disease. So nothing make me happier than preventing a person from going on dialysis. The beauty about the clinic week is you're done and you don't have any pages, nobody interrupt you. So, it's good. Now, there is another part of nephrology that was make it lucrative. So, we talked about all these hospitals and clinic weeks and so on, and all the aspects of management of really taking care of patients. But there's also, you can be a medical director of a dialysis center, and that where you basically, in one day, you can earn what you earn for a week or two working and taking care of patients. And that really require that you oversee the quality and outcomes in the dialysis center. You meet with the multidisciplinary staff and review their quality measures. And a lot of this is those dialysis centers using kind of your license to run the dialysis center. But they also have, basic quality measures that they have policies and procedure by the dialysis company. So basically, we're just overseeing quality. So that is lucrative. That's the side of the side of nephrology that people oversee, that they think about only about patient care and about being on call and so on. That is a side that you should always consider, and you should always think about if you're ending up going that route. Now, medicine is changing, and who knows what's going to be in the future, but it's something to keep in mind. So I want to a little bit talk to you about our integrative nephrology and what I think about what are the integrative principles. So and this is why this is so important. Kidney disease is not going anywhere. So 1 in every 7 people in the US have chronic kidney disease. And actually, this data is also the same in the world. Throughout the world, 10 to 15% of the world population has chronic kidney disease, and it's very, very costly. Dialysis is not cheap. caring for dialysis for kidney patients in general cost Medicare $81 billion in 2018. So, and if you add the care for dialysis patient, you're talking about more than $100 billion every year. That's only in the United States. So when you talk about kidney disease, there's this continuum. You have risk factors, early kidney injury, kidney disease, then kidney failure, where we do dialysis or transplant. And unfortunately, down the road, the patient ends up dying. And throughout this, there is continuum of cardiovascular disease that is happening. And conventional medicine approach is just basically, you have early kidney injury, we'll try some medication. You have kidney disease, we'll try medications. Cardiovascular disease, we'll try medications. And if you have kidney failure, we'll do dialysis or transplant. Nobody think about the risk factors, approaching the risk factors, why the risk factors are there. So in our integrative approach to kidney health, I'm not gonna bother you too much about talking about these in details. If you're interested in learning more about this, like I said, go to our website. I'm also on Instagram, and we talk about genetics, the genetics and epigenetics basis of kidney disease. We talk a lot about nutrition. We talk about environmental toxin exposure. The relationship between the gut and the kidney is really important. We know that the gut is the size of 2 tennis balls. Can you imagine this? Your belly has the size of 2 tennis courts in your 2 tennis courts, not tennis ball, 2 tennis courts in your belly, and has a lot of microorganisms that interact with the body. So the health of your gut is super important for your health of your body and the health of your kidneys. And lifestyle is super important. If you're exposed to stress, if your sleeping habits are bad, you're not exercising, you're drinking or smoking and so on. So a lot of these stuff are important for kidney health. And we do incorporate medications in kidney, in our medication, in our integrative approach to kidney disease. So what are my advice to you? My advice to you is, think about, medicine is really changing. The world around us is changing right now. If we learn anything from the past year, that things are not going to continue going as they used to be in the past. So we're seeing a lot of telemedicine, telehealth right now. So I don't know where the world is going to be, but we've seen a lot of shortages of physicians, a lot of regulation changes, and the problem is that you're seeing a lot of changes where, like, there's all these allied health providers are also taking some of the jobs that our physicians used to take. So I really, in position that I would not like to be called provider, I would like to be called physician. So you should, strive to have that too in the future. But don't forget to keep an eye on this changing world around us and see what's going on around you. I don't know what's the future is going to hold, but the way we practice medicine now is not going to be. I think in 5 years, we're going to see a lot of involvement in genetics and a lot of changes in AI. So it's going to be, artificial intelligence is going to be running a lot of the shows for us, and precision medicine is happening also. So think about those things. And really, is this something, what do you want to do? What do you want to think about? Think about, the specialty you want to have, what you're passionate about. Don't go the route where the path of least resistance. Follow your passion and go after it, even if it's going to take longer, because your happiness down the road depend on that. Depend on you accomplishing what you really want to accomplish in life. So just really pay attention to that and think about your passion. Think about your lifestyle. So like I told you, nephrology have, some bad days and has some good days. There are some other specialties where it's all bad days. Some other specialties that is, you go to your clinic, you take care of patient, and you're done. There are shift based that are, you just do, you go on your shift, and once you're done, you're done. Take control of your life, take control of your future, and don't let anybody else dictate what you want to do and what you should do. Always be in the driver's seat. Don't let anybody, whether it is whoever it is, or even an administrator down the road, dictate how you should practice medicine. And we talked about the lifestyles that you want to have in the future. So I'm open to questions and here, and also if you have any questions for me, you can always send them to my email, dr.isreb@inkidney.com. And I'm also on Instagram at dr.isreb on Instagram, and Integrative Kidney. Also, I hope you will follow us there, because it will really mean a lot to us, to me. Open for questions.
All right, thank you so much for the presentation. Really informative, really inspiring overall. Really love what you do. We do have a couple of questions here. I see Tracy raised her hand, but let me get to Bella's question here first. So the question is, have you ever felt burnt out due to the business side of healthcare and insurance coverage for patients?
Absolutely. I mean, definitely, this is really the part of medicine that is frustrating. I mean, the other, last week we had a patient, we're getting the runaround. We're just like trying to, what do you want us, which medication you want us to give the patient? And 1 week you get this answer, you do the paperwork, come back, and they will say something else. So that's the bad part about the current day medicine, is that, the insurance world and changing in pharmaceuticals and who's trying to make most money from healthcare and it ended up, and the physicians are getting the bad rep when it's not a lot of stuff are in our hand, unfortunately.
All right, thank you. And Tracy raised her hand. Let me just mute you for a sec.
Hello, thank you so much for your presentation. It was amazing. I wanted to ask, you talked about telemedicine earlier, and I wanted to ask if you partake in doing telemedicine during the pandemic, or how has healthcare changed during the pandemic, and has it helped you, or has it made it more difficult for you?
Yeah, so our hospital, system incorporated telemedicine in the electronic health records. So in the beginning, we have a period of time, there was everybody was stunned, really. So in the beginning, we did not have a system to do Zoom visits. So we ended up having telephone encounters. And really, you cannot learn much of anything from a telephone encounter, and then after a few weeks, they had this link with Zoom, and we do Zoom visits. The problem with nephrology is you really, sometimes a lot of patients are, I don't want to be, saying bad things, but, some of them are non-adherent. So if you are talking to someone on Zoom and you don't know what their blood pressure is, their blood sugar is, and what they're doing, then you're not able to make any impact. And I'm not just there to just chit-chin on visiting a patient. I need to make a change in their life. So it is my preference that I see the patient in person. And we're not talking about sore throat or some URI or something. This is, a lot of it is chronic disease management, and we have to see if they have edema, we have things like that, and examination. is important. So some patients can be good candidate for telehealth, but a lot of others require face-to-face visits. But
Awesome.
yeah, we didn't have telehealth before. We didn't have that option, but the pandemic made it like available for us.
Awesome. Thank you. We also have another question from Jasmine, and she asks if nephrology is heavy on math and physics, and what advice would you give to the people who are average in the subjects?
So, like I mentioned, there's a lot of math and physics, but this is not what we do day to day. So, there's things that are there are books that makes things easy. There's like electrolyte made easy, like handbooks, small things that can be read. But an acid base made easy. There's a lot of things that we can be easy review for you. But honestly, again, your majority of your work is going to be not in those math formulas. I mentioned that at some point, like nowadays, I regret when I get a consult for like sodium abnormalities, because there is a lot of liability associated with it, and correcting sodium level too fast can lead to big problems that can lead to whatever, and it's going to be a thing that's going to make you up all night long to make sure that the sodium is correcting at a good rate, for example. So and these are the formulas that we talk about is associated with those electrolyte imbalances. So in a way, that's what got me in, but now I feel it's more like it's the negative aspect of it. But yeah, don't worry too much about it, because it's there's a lot of resources to help you study those.
Perfect. Really reassuring. And Jasmine also wants to know. She's wondering, she's heard that what's good for the heart can be bad for the kidneys, and she wants to know a little bit more about that. And she also wants to know if you work with under any other specialties.
Yeah, I mean, I actually don't think that's true. So, there are some things where you get in a situation where, fixing the heart may affect the kidneys, but that, and actually a lot of stuff that we do to keep the kidney healthy are also things that supposed to be good for the heart. So I don't believe in that what's good for the heart is bad for the kidneys. I reject that. We work with a lot of other specialties. So we work with cardiology closely. There's this cardiorenal syndrome where people end up, having to have this balance between the heart and the kidneys. We work a lot with endocrinology, some of the, especially taking care of diabetic patients. And, there are some, electrolyte imbalance, especially hypercalcemia or calcium, things are related to endocrinology specialty. One of the major specialty we work with is vascular surgery, especially for dialysis access, because we need those dialysis access for running smoothly. So that is probably the primary specialty that we deal with in general, surgery. And I mean, we hospitals, we cannot live without the hospitals because they take care of all our patients. And then the primary care physicians are our source. So yeah, so we deal with a lot of specialties, and I can name all of them pretty much. The one thing I forgot to mention is that, I in a previous meeting, someone asked me if we do any procedures in nephrology. So in general nephrology, you can learn to do kidney biopsies, and you can learn to do dialysis catheter insertion for acute dialysis. These are not tunneled catheters. These are like the catheter that just can go in and out. There are subspecialties in nephrology, as I mentioned, where you learn interventional nephrology, where you can fix those dialysis access, put tunneled catheters, and do more intense procedures really for in nephrology. So a lot of that is, some of it you can do as a 6 weeks program and then get grandfathered into it. So yeah, sorry, this is just something I forgot.
Yeah, great. And Bella asks, just wondering if you know of a job as a nephrologist that we can look into to help the insurance side be more efficient, similar to when nurses and therapists do audits, utilization reports, but working for insurance companies.
I'm sorry, I didn't understand the question.
Yeah, a bit of a loaded question there, but she's wondering if there is a job that the students can look into if they want to help with the insurance side of medicine in general.
Yeah. So I mean, there are a lot of non-clinical jobs in medicine, and including nephrology, that you can work for the insurance company. You can work for utilization and review and audits cases. This is like, we call it, you went to the dark side, but yeah, I mean, if you're good-hearted and you're able to fix things from the other side, it's great. But oftentimes, I see people, the prior authorization, all these documents come to me is like signed by someone who is a doctor, or sometimes a pharmacist. So, and so you will think, what did you sell your soul to the insurance company when you went there? Who knows? So I think it's available. There's a lot of non-clinical jobs that you can do, but my passion is taking care of people.
Perfect. All right. Does anyone else have any other questions for Dr. Isreb today? Okay, and if not, that's perfectly okay. You can see that Dr. Isreb has already plugged in his social media and his website. So if you have any questions, feel free to message him on those platforms. All right, it looks like those are the questions for today. I want to thank you so much, Dr. Isreb, for taking the time out of your busy schedule to speak with us and really educate us on this specialty. It really means a lot.
Sure.
All right.
Have a good day, everybody.
Thanks so much, Dr. Isreb.
Thank you.
And for everyone who is still attending the session currently, Google Forms link will be posted in the chat. It's actually there right now. So there's not going to be any formal assessment where you have to answer 10 questions based on the presentation. It's just checking to see if you attended the session, and that will give you the hour for the session. Okay. All right. Thanks so much, everyone. Take care.